Good evening, welcome. Thank you for coming and thank you for allowing me the opportunity to speak. The day you get diagnosed with cancer, your life changes. If you're a young woman who hasn't had a child, one of the first things you think about is that part of your life. Um, it's perhaps a little different than a young man. Uh, and I guess there's a lot of reasons for it, and it's not a criticism, it's just a fact. Um, the idea of being cured of cancer and being infertile is not really being cured of cancer, because if you lose a piece of your life, such a big piece of your life, you're not really cured. Um, of course, life and death with a diagnosis of cancer is paramount and thought about a great deal. But nowadays, with cancer treatments being as effective as they are, many more people are being cured of cancer, and they want to have a normal life after their cancer. And that's why this great interest in fertility preservation, and a whole new field has evolved called oncofertility, which relates to having fertility after cancer treatment. So that's what brings us here tonight. So I'm going to talk about egg freezing. So I just want to show you that this is a real thing. This is our first baby born from egg freezing in 2004. And despite spending the first few months of her life in the freezer, she, for some reason, has a predilection for warm summer sports. She just didn't take to skiing very much, but um, this is a real thing. It works. We can make babies from it, and that's what I want to talk to you about. It's not a new thing. It's actually the first baby from egg freezing was in 1986, but there were a lot of technical hurdles that had to occur for this to be really efficient. And say, well, why would you want to freeze eggs in the first place? What's the idea? Well, there's actually a number of indications, and for tonight's talk, the main topic is preserving one's fertility, because many of the treatments for cancer damage the ovaries and damage the eggs and compromise or make one infertile. And that's a tragedy. There are other reasons why people freeze their eggs, and I'm not going to get into these other indications, but there are a number of women who are delaying childbearing on purpose, knowing that that will affect their fertility, and they want to have some insurance in the bank for when they're ready to have a child, because they may be infertile because of age. So that's a controversial use of this area, but it's something that's evolving and being done more and more. Patients who hyperstimulate from the treatment of in vitro fertilization, where they get lots of eggs, we can't put embryos back in those patients, and sometimes we just freeze their eggs to prevent them from getting sicker from the hyperstimulation. And then there are a number of women who are unable to get pregnant with their own eggs, including many cancer survivors, because their eggs are old or damaged. And we do a process called egg donation, where a young, healthy woman's eggs are used to help a woman conceive a child. She gets to carry the child, deliver a child, have a birth certificate where she's mom and the partner's dad, and be able to have a normal family life when before that it wouldn't be possible. So we're going to focus mainly on the preservation of fertility. And like I said, freezing eggs is not a new thing. The first baby was born in 1986. That's a long time ago. We weren't very good at it. Eggs are very different than sperm. Sperm are actually very simple to freeze. They're a package of DNA with a tail. They're very small. They don't get sheared by ice crystals because of how tiny they are. So when the ice crystals form, they rarely damage the sperm. And there are millions of sperm. So eggs, completely different. It's one of the largest cells in the human body. There's a lot of water, and there's also intricate and delicate infrastructure that has a job to perform, that with sperm the job has already happened. And if you go back to your high school biology class, and I'm not going to get into it too much, but you remember a process called meiosis, where a cell goes from having the 46 chromosomes that all our cells have to becoming an egg or sperm where it has 23 chromosomes, because as you know, when fertilization occurs, 23 chromosomes comes from the egg, 23 comes from the sperm, and you reconstitute the 46 chromosomes. Well, that process of meiosis is very different in sperm and in eggs. And in fact, a woman has all her eggs when she's a fetus in her mother's womb. She has about 7 million eggs at 20 weeks gestation. And when she's born, she has 1 to 2 million eggs. And when she hits puberty, she has about 400,000 eggs. Most of the eggs are used up before a woman is even reaching the fertile years. And every month, she recruits 1,000 eggs to ovulate one good egg. And actually, at age 30, 87% of the eggs are gone. At age 40, 97% of the eggs are gone. But, you know, 400,000 eggs, if you still have 3%, 14,000 eggs are a lot of eggs. But these eggs sit in the first stage of meiosis, where the chromosomes get divided. And that infrastructure and machinery for that process is what needs to be protected when we freeze and thaw eggs. And sperm don't have that problem. And so that's what's made egg freezing a lot more complicated. And in the early days of egg freezing, pregnancy rates were very inefficient. Maybe 1 per 500 eggs made a baby. Not very efficient. Although actually not terrible. And this is one surprising thing I think most people don't realize. And you really, if you think about it, you have to look in nature for other examples of this. But in vitro fertilization, where, you know, in the United States last year, 100,000 cycles were done. And in our program, where depending on the age of the woman, we have very high pregnancy rates. About 1 baby is born for about 20 to 25 eggs. You say, well, why is it so inefficient? Well, nature is inefficient. I mean, go out in your backyard, drop 100 seeds on the ground. How many plants do you think you get? Average germination rate for seeds is 10%. So that means 90% of seeds don't make plants. And it's the same with eggs and embryos. Most eggs don't make healthy embryos. Most embryos that are created in nature and also in the IVF lab are not healthy. The chromosomes have been scrambled by the process of meiosis and also the recombination events that occur to make for changes in our DNA and evolution. And the process is very inefficient. In fact, it takes 13 months for 100% of 25-year-old fertile couples to get pregnant. And that's peak fertility for women. And as I described earlier, fertility changes with age. In fact, at age 40, the fertility is half what it was at age 30. And at age 30, it's already slightly compromised from peak fertility of 25. But in that 13 months of trying, what happens is these couples are making eggs and making embryos. It's just that most of them aren't good. And 1 month, that one good embryo makes a baby. But you have to really understand how inefficient this is. And it's not because of what happens in our lab. It's because nature designed the system that way. And so if you have an inefficient process and now you mess it up with something like freezing and thawing an egg where you're damaging eggs even further, you're not going to get many babies. And that's why we weren't very good at it. And back in 1986, we were still learning how to do IVF, and we weren't very good at it. And it took many years to learn how to make IVF more efficient, in vitro fertilization more efficient. During that time, more and more cancers were being cured, and more women, young women who were cancer survivors, were struggling because they were cured, but their life wasn't cured. And of course, they had other options. They did egg donor or they adopted babies. But the idea of being able to preserve your fertility prior to cancer treatment was thought about at that time, and people were starting to do it. But no one really had a good sense of how successful we would be. So there was a lot of research going on through the 90s and still ongoing to make that more efficient. And how did that happen? Well, turns out the Italian government practiced medicine for many years. And this is a kind of a theme that we see throughout. People who regulate the process of medicine and make decisions about medicine sometimes have unintended consequences of their decisions, not because they're not well-meaning, but often because they haven't done all their homework to really understand. And in Italy, the Italian government, along with the Catholic Church, had a lot of problems with in vitro fertilization. The idea of us creating embryos in a lab was offensive, and they passed a law in Italy that said infertility patients who were being treated from IVF could only have 3 eggs fertilized, and the rest of the eggs you couldn't use. So when we do in vitro fertilization, one of the reasons we're so successful now is we stimulate a woman to get a lot of eggs, an average is 10, and of those 10 eggs, we're hoping to get one good embryo. The fewer eggs you have to start with, the lower the success rates. So it's no surprise that in Italy, patients who were treated by someone like me had much lower chance of getting pregnant because the Italian government was practicing medicine and doing it badly, by the way. But, you know, nothing's all good or all bad. People like me in Italy started thinking, well, gee, what am I going to do with all these extra eggs? I better learn something. And they started researching how to freeze eggs, and they got better at it. So pretty soon the 5% success rates became 10%, became 20%. And next thing you know, all of a sudden, it starts to sound like a viable option for fertility preservation. And so lots of research has gone on over those years, some of it here at NYU, and that's what I'm going to talk to you about. So this is one study, and I don't want to get too bogged down in the numbers. It's just to kind of, really the main thing I'm trying to show you is how inefficient this is. Pregnancy rates of 17%. Look at how many eggs, from 737 eggs, of which only 273 survived. You've already lost a large percentage of opportunity. And then when you try and fertilize them by microinjection, not all of them fertilize. And then when you watch them develop, not all the embryos develop. And pretty soon at the end, you're left with, from 737 eggs, only 104 embryos and opportunities for someone to have a baby from these frozen thawed eggs. And, you know, pregnancy rates of 17% are pretty inefficient. Although back in the early days of IVF, those were good. Now, in our program, a 30-year-old, 62% of cycles results in a baby. A 35-year-old, about 50% of cycles results in a baby. At 40, 28% of cycles result in a baby. At 44, 6% of cycles result in a baby. So you can see how age impacts the fertility. So whenever you look at pregnancy rates, you also have to know the age of the patients. And in these studies are relatively young patients. And, you know, 17% is respectable and improvement, but not great. This is a colleague of mine, Jeff Bolt, who actually helped us with our egg freezing program. You know, there were lots of theories about why freezing an egg damaged it, and one has to do with what happens to fluid shifts and water and ice crystals that damage the cell. And Jeff's a pretty smart guy and said, well, we know there's a lot of things that happen with sodium, and if we could substitute the media with sodium-free media and use a substitute for the sodium, we would see a lot less damage. And he worked on a method using sodium-depleted and using the method similar to the Italians, which is called the slow freeze method, where the temperature is slowly lowered until you reach the temperature of liquid nitrogen. And you form crystals under very controlled circumstances and don't damage the eggs. But even Jeff's results, a 28% clinical pregnancy rate, was an improvement, but it's still not kind of the number we're looking for. And again, you can see the degradation, the loss of eggs, 361 thawed, 218 survived, 60% survival rates, not ideal. You know, fertilization rates of 62% and pregnancy rate of 28%. So, and you know, his efficiency, about 4 eggs were required to get an implantation to make a pregnancy. It's not very efficient. So, or 4% of eggs made a pregnancy. That's not a very good number. There was a technical breakthrough using a different way of freezing eggs called the vitrification method, which is kind of like freeze drying. So what you do is you dehydrate the cell and then you flash freeze it. And the advantage to this is there are no ice crystals because there's no water. So you don't get the damage. So the investigators, Kuyama, Asian investigators, studied this method, and all of a sudden, now we started to see pregnancy rates that were very significant. 41%, pretty much at that time, was a very respectable pregnancy rate, almost as good as regular IVF. So, you know, you can see how slow progress is, but and how many people are involved in making progress happen. There's so many investigators in our field, and every year we meet at an annual meeting and present our data, and try and improve the specialty. And so that's a wonderful thing about what we do is, we share these technologies and try and make everybody better by doing it and help more people by those efforts. Well, then the question became, which is the best method? Should we use the Italian method of slow freeze, or should we use the vitrification method that Kuyama had developed? And here's one study that suggests that the vitrification method is better. In this example, they had a double the pregnancy rate, 18% pregnancy rate with the slow cool method, Italian method, and a 34% pregnancy rate with the vitrification method. And this is more recent, but we started our research, and we do everything in the animal system first, and we really were confused about which method to use, and I'll go into more detail about how we made those decisions and what we did. Other investigators tried to perfect techniques different. This is a different method of storing the eggs, the cryotop, which is a way of not losing the eggs and freezing them more quickly and more easily, and respectable pregnancy rates, still not equal to that of IVF. So with these kind of numbers, this became a more viable option for fertility preservation. No, it wasn't perfect, but when you talk to a cancer patient who was about to have her ovaries damaged by chemotherapy, who was told, look, you're going to be cured of your leukemia, but you're not going to be able to have a baby, and you say, well, we have a technique, it's maybe 30-40% chance of you being able to have a baby, a lot of patients are interested in that. And so, the advantage is, we're not freezing embryos because that's complicated. What do you do with a frozen embryo? And what if you never use them? And what if you die of your cancer? What do you do with a frozen embryo? And does that create a problem for the family? You got to think about these things, when you're practicing medicine. You got to think about the impact of everything that you do and who it affects. Because when you have a cancer patient, you have a whole family. You don't have just one patient. You have a family. And you have to think about the impact of everything that you do on this family. The problem is it requires about 2 weeks of stimulation. We have to give these women medicines, we actually teach them to inject themselves for about 2 weeks while we stimulate their ovaries to make lots of eggs. So during that cycle where they recruit the one follicle on a natural cycle, what these medicines do, instead of wasting 999 of the eggs that are recruited on that cycle, we're able to get 10, 20 of those eggs to be mature and viable and able to make a baby. And that's what these medicines do. But that process takes 2 weeks, and it does sometimes delay the initiation of cancer treatment, which may be a factor. And also, what's the impact of these medicines on a cancer patient? Will it affect their cancer? Will it make it worse? Will it affect their survival? Unanswered questions. But, at the present time, there's been well over 1,000 babies born from egg freezing, most of them not in cancer patients, but most of them in the Italian literature, because they were the leftover eggs from the IVF cycles that, instead of being discarded, were used to learn how to do egg freezing and help people have babies. Now, this technique is still considered experimental by the ASRM, that's the American Society of Reproductive Medicine, and also the American Society of Cancer Oncologists. But we, after spending many years in the lab, got to a point where we wanted to see what our pregnancy rates were, and we did a trial, and I'll talk about the trial. But, we actually demonstrated that we could get pregnancy rates with frozen thawed eggs that were equal to fresh IVF, and that was a big step forward in progress for fertility preservation. But at the time we were designing our experiments, and we first did this in the mouse system, because it's not like when you do what I do, you just walk into the lab and say, yeah, I'm going to freeze eggs, and just freeze patients' eggs. You gotta base it on something, and everything that we do is based on animal research and literature. Not that we did all of it, but there are certain things that you have to do yourself. So we spent years in the lab in a mouse system looking at mouse eggs, freezing and thawing them, and making mouse babies, and making sure they were healthy, and making sure the techniques didn't damage eggs in ways that would be unanticipated. And we debated about which methods to use, and we actually, rather than trying it out in human first, we spent a couple of years in the mouse system and looking at the different methods, slow cool versus vitrification. And then we got to a point where we knew we could do this, and we got to a point where we were going to do it in human, but not until we had this kind of data. So if you look at the control group, those are that's fresh IVF. And by the way, mouse IVF is very complicated, in some ways more difficult than human IVF, especially when you're talking about doing the ICSI procedure where you inject the sperm into the egg. And all frozen thawed eggs need to be fertilized by ICSI. So it was a technical feat just to be able to even collect this data. But we did the hard work that needed to be done. And we actually showed with vitrification, we could get results that were pretty similar to fresh eggs that weren't frozen or thawed. The slow freeze method in the mouth system, for whatever reason, did not work as well. And that made us think we might just do vitrification, but since there was a lot of experience in human with slow freeze, the biggest worldwide experience with slow freeze, we didn't want to just discard that method. And we also wanted to prove that we weren't doing damage and doing harm, because the last thing we say before we walk off the stage when we get our medical degree is first do no harm. We're trying to help, and we take risks in trying to help, and developing new techniques is risky business, but without risk there's no rewards and there's no progress. But we take these responsibilities seriously. So here's an example of showing the spindle, which is the chromosomes in mouse eggs, and showing that freezing and thawing did not damage the spindle, and that's what those pictures show. These are eggs that have been frozen and then thawed, and those look identical to eggs that were never frozen. And we showed that the chromosomes in blue that you can see on the bottom, we could actually count the spots and make sure all the chromosomes were there after we froze and thawed the eggs. So. And then we made mouse babies, and then we made sure that the mouse babies were healthy, and then we made sure the mouse babies could reproduce. And then, and only then, did we say, okay, now we're ready to offer this to patients. And the way we've done everything in our program is, in order to offer something to a patient, we did it for free, because we didn't know if it was going to work. We didn't know the outcome. So we actually designed a study and went to the Human Investigation Committee, the IRB, Institutional Review Board, and said, we want to do this. And it was funny, their response was, well, wait a second, is egg freezing new? Well, no, it's been done. And you're just offering it to patients? Well, you don't really need IRB approval for that. So we got stopped a little bit because we didn't know if we could do this without it. There was the trend that everybody said we should have IRB approval. It took us a year to finally sort all that out, and we got to the point where the IRB said, go ahead and do the study. And what we did, we offered a free cycle of freezing eggs in patients who are going to be treated for in vitro fertilization. And we did this because we said to them, look, we want to learn about egg freezing. You want to have an IVF cycle. You can't, your insurance doesn't cover it. You can't afford it. Here's an option if you want to participate. And here's the informed consent that has all the things that could go wrong. And are you willing to participate? And patients, was actually pretty easy to recruit patients. And what we did, because there were so many babies from slow freeze and there were fewer from vitrification, we decided we would take half of the eggs of each patient, do slow freeze in one, and half the eggs, and vitrification in the other. And we froze all the eggs, we waited a few cycles, and then we brought the patient back, we thawed all of the eggs, we fertilized them all, we watched them develop into embryos, and then we gained a lot of data about our methods, and we actually, during the study, were able to improve the method, and we were very happy to see great success with this technique. We took 22 infertile patients, one patient cycled twice. We gave them the medicines to stimulate their ovaries. We took the eggs half by slow freeze and half by vitrification. And we had a 57% live birth rate, which for the group of patients that we did, the mean age was about 33, was identical to our pregnancy rate with fresh IVF. Using statistical analysis, we showed that we had the exact same pregnancy rate with IVF as with frozen thawed eggs. And we weren't sure whether the slow freeze method was better or the vitrification method was better. We got babies from both. A lot of the times we had one embryo, the best embryo was from one method, and the other best embryo was from the other method, so we did mixed transfers. So we don't even know which of the embryos made the babies. And we published this. It took us about 3 years to get it published, because when you publish something that's, not well accepted because nobody else has been able to do it, and they call it peer review, but I actually sometimes think it's more like peer suppression. Your own colleagues don't want it published because they can't believe that you did it. In fact, one person rejected our paper because they said we were lying. Peer review is anonymous, so you don't know who said that, but it was pretty amazing. That was one amazing day for me to hear that. But we weren't lying. This really worked, and it really worked well. One of the things that we do is we try and collect as much information as we can and to learn about these techniques because we have limited opportunities. So we used an instrument called the Pulscope, which allowed us to look at the spindle, and that's what you see, that bright spot. That's the chromosomes. And we wanted to look at that because we were looking for markers of viability, things that would tell us, is this egg a good egg? Is this egg not a good egg? Will this help us, in advising our patients about what their success is? And, when we looked at our thaw cycles, I showed you the study before where we had the 57% baby rate. Since that study was published, we've thawed 10 more patients. None of these cancer patients, but these are just patients from the fertility group. And we transferred a total of 58 embryos, and our live birth rate still didn't change. It was the same number. 56% is the same number as 57%. We were able to gain information about the meiotic spindle, and when we see the spindle, that tells us the egg is good, and those are the eggs that make babies much more efficiently. So then we had a prognosticator. All right, we froze your eggs. We saw a spindle in X percent of your eggs. You have a better chance. We didn't see as much spindle. You have a lesser chance. So, because patients need to hear what their chances are, because they have a lot of hope in the freezer. We want to give them as much information as they can. So we've learned a lot by doing this. And the cancer patients, we haven't thawed many of the cancer patients. We thawed one actually because we've only started doing this clinically in the last several years, and many of the cancer patients are still finishing their cancer treatments. They're not yet considered cured, and they haven't used their eggs. But what we showed in this study was that we saw the same parameters in the cancer patients as we did in the elective patients, the non-cancer patients who we did the original study on, the infertility patients who were going through the study to help us determine how good we were going to be at this. And we found that we certainly gave more medication to the cancer patients because they had one shot at it. We really stimulated them to get as many eggs as we could because they had one chance to get eggs in the bank, so to speak. So that was really the only difference between the groups. And you can see, despite this increased amount of medicine that we gave them, that's the total dose compared to the non-cancer patients. They didn't get as many eggs because when you have a chronic illness and you're sick, your body doesn't respond as well. So that's one thing that we learned. So that's helped us determine the doses of medicines to use to get maximal recovery of the eggs. So we were able to show that we got respectable pregnancy rates with egg freezing. And we're now offering this for cancer patients. We're also offering it clinically for patients who want to delay childbearing intentionally and not have to be the patient who uses egg donation. In a sense, they get to freeze their own eggs so they can be their own egg donor if they need that down the line. And one of our patients, I can give you an example of that, was a 38-year-old who came to see me right when we started doing the studies. And in fact, she had heard about what was going on, and through her obstetrician, who was a good friend of mine, who we share a lot of information. And this poor woman had just ended a 10-year marriage and had never had a child, and was looking at the clock ticking and thinking that she would never have an opportunity to have a child because now it's going to take a while to get over being divorced and find another partner. And she just sat down and said, just freeze my eggs. I don't care what it costs. I don't care if you can give me a 10% chance. You give me any percent chance. It's better than nothing. And so we froze in this patient 9 eggs. And, as luck has it, a year later she met the guy, and 2 years later she got pregnant, and 3 years later she was ready for number 2. And at 41 and a half, she was not able to get pregnant. So we put her through fertility treatments. In fact, she didn't want to use her frozen eggs at that time. She wanted to hang on to them because she thought she might want to have a third child. So we did in vitro fertilization, and she got pregnant with twins, and at 8 weeks miscarried, 2 chromosomally abnormal twins. got over that, and then at that point she was almost 42, where our pregnancy rates in IVF are somewhere around 25%, and between 42 and I'm sorry, at 42 actually it's about 14% compared to 25% at 41. Um, well, we looked at our frozen and thawed egg data, and I said to her, look, you have these frozen eggs that will give you a much higher chance, probably about a 40% chance. So we thawed her 9 eggs, transferred 3 embryos, and she delivered a baby last December, a year ago. The baby's 14 months old now. And of course, she called me a month afterwards wishing that she had frozen more eggs and chastising me for not making her do that. These are the hazards of my job. But those eggs had been frozen for 4 years, and we had a good outcome. So, we think we can keep these eggs frozen for a long time. We certainly, with embryos, have had embryos frozen 15 years and made babies from them. So, once you get something frozen, it's stable. It's the freeze. It's kind of like takeoff and landing. Bad things happen in a plane, usually either landing or taking off. Once you're up in the air, things are okay as long as you keep things under control. And it's the same with freezing. As long as you keep the conditions right, the eggs behave like the age of when you froze them, not the age of when you're using them. The American Society of Reproductive Medicine has published a position paper, and I'm a member of the ASRM. In fact, I was the past president of one branch of the ASRM SART, which is the Society for Assisted Reproductive Technologies. And we try and improve our specialty by communicating and making decisions and recommendations for how we practice to do it well. And the ASRM says egg freezing should be done with IRB approval. They still call it experimental, and I think part of the reason for that is there are many clinics who've never had a baby from egg freezing, and they're freezing eggs. And that to me is wrong. If you're going to do it in your clinic, you got to prove that it works. And that's why we did the animal research that we did. That's why we did a free trial first to make sure that we were offering it to patients. Just because another lab can freeze eggs and make babies doesn't mean your lab can. And we learned a lot about our method and tweaked it. And so I think a lot of the reason they keep calling it experimental is a lot of clinics are offering it without having done what we did. And that shouldn't be done, but that's the way it is. They also were pretty negative about the way they presented the data. They looked at the literature and said, look, only 2 to 3% of eggs make babies. This isn't very efficient. You should really consider whether you should do this at all. And I always had a problem with the way they presented it because they'd actually never looked at IVF presented that way. The way we present IVF statistics, if you do a cycle, what's the chance you get a baby? And that's a different number. But they weren't presenting egg freezing data that way. They were presenting egg freezing data as a percentage of eggs making babies. Well, I've looked at our percentage of eggs making babies in IVF, and guess what the number is? 5%. And guess what it is for egg freezing? 5%, 4.9%, same number. So, yeah, it takes a lot of eggs to make a baby, but I told you that in the very beginning before we even talked about freezing them. That's nature. That's the system. That's the way it works. But that's what you have to explain to patients so they understand because, they think, oh, I have 20 eggs in the bank. I'm going to have my whole family. If we get 1 out of that 20, you'll be lucky. So, I think when you're practicing medicine and you're doing new things, it's really important, and the consenting process is complicated, to just let people know what we know and what we don't know. There's a lot of things we don't know. I mean, with only 1,000 babies or so being born from egg freezing, is every baby going to be healthy? Well, so far they've been studied, no one's found a problem. But are we going to find something 10 years from now? Probably not, but we don't know. But we got to talk about these things with patients so they make informed decisions. The good news is we've been doing IVF for over 30 years, and we haven't really found any significant differences in babies born from IVF, except the complications of multiple pregnancy and prematurity, and maybe some other subtle things that are unique to the infertility population. But again, you have to inform your patients. Are these drugs going to affect their cancer? We don't know. We don't have enough data. Are these drugs going to affect their recurrence rates? We don't know. There's a lot of data, though, and there's years of experience now, and we haven't found any problems, but it's not definitive yet. There are unknown risks that are out there that need to be talked about, although the data that does exist is very reassuring and makes us think that we are doing much more good than harm. So a lot of people are involved in this. I mean, our embryologists do a lot of work, freezing eggs and keeping the conditions right. The doctors that are involved, our whole team, and our collaborators. Alana Porcu is one of the Italian investigators who shared with us her slow freeze methods, and that's the one we use. And Jeff Bolt shared with us his methods. We're not using his methods. We developed our own vitrification method here in my research lab. And that's the one that we use for our egg freezing. So I think that's where I'm going to leave it. I love babies. Actually, this is my daughter. When her much older brother decided it was time for her to listen to his iPod, and I heard the cackling, and I came and took the picture, and he looked at me and said, "Dad, she's cool. She likes Jerry." Jerry Garcia, Grateful Dead. Anyway, if you have any questions, I'll be happy to answer them.